Good evening, ladies and gentlemen. My name is Hilmi Chang. I'm a neuroendocrine cancer patient here in SGH. I'm undergoing a PRT actually. Well, this evening we are going to be hearing about some new developments in this field of neuroendocrine cancer medicine. We are very fortunate this evening to have two internationally renowned experts in this field, Dr. Bodei, who will be talking about dosimetry on PRT, and Dr. Milan, who's going to be here in a short while, who will talk about biomarkers for neuroendocrine tumors. This event is organized by CNETS and is made possible by the generous sponsorship of Novartis Oncology as well as the Academy of Medicine of Singapore, especially the College of Radiologists, Chapter of Nuclear Medicine and Chapter of Pathologists. Just so you know that we are recording this session and it's being webcast simultaneously to some members of our society residing overseas so that they can participate alongside with us today here. Before we start, I would like to first introduce Dr. Liao Ku-hin, who will kick off the program. Just a little bit about Dr. Liao. He is a hepatobiliary and pancreatic surgeon in private practice in Singapore. Before that, he was the head of the hepatobiliary and pancreatic surgery department of Tan Tock Seng Hospital. And he has tremendous interest in neuroendocrine tumors, and he's currently now the secretary of our association, CNETS. So please join me in welcoming Dr. Liao.
Thank you, Helmi. It is indeed a great honor for me to open this afternoon program. And also, I have the pleasure to welcome our guest speakers from Italy, Milan, to give us the talk. Dr. Bodei is the Deputy Director and the Nuclear Physician in the Department of Nuclear Medicine, Division of the European Institutes of Oncology in Milan, Italy. As you know, she is one of the pioneers in the field of radiolabeled peptide therapy. And she is very experienced. She has done lots of research and studies in this field. And this afternoon, we are privileged to have her to give us a talk on the accurate dosimetry for the peptide receptors radionuclide therapy. Please.
So thank you very much for the introduction. Thank you very much for inviting me here this evening. Talk about dosimetry for peptide receptor radionuclide therapy. Peptide receptor radionuclide therapy has the rationale in the internalization of peptide suitably radiolabeled, which is transported inside the cytoplasm of neuroendocrine tumor cells where the radioactivity is trapped, thus giving rise to the therapeutic radiation. Usually PRT, which is the acronym for peptide receptor radionuclide therapy, is divided in multiple cycles administered intravenously until the maximum cumulative administrable activity is reached. And this maximum administrable activity depends on mainly on renal irradiation. PRT actually is not new and has a long story behind. And we can start with the story talking about when somatostatin was first isolated. We can jump to the synthesis of octreotide, the first indium octreotide scintigraphy in the early 90s, the first therapy with a high dose indium octreotide, so the high dose of diagnostic compound given for therapeutic purposes at the beginning of the 90s again. And then the first therapy, PRT, with the yttrium peptides in 1997, the first PRT with lutetium octreotate in 2000, and nowadays we have ongoing, still for a few months, the phase 3 registration trial of lutetium octreotate, which started off in 2012. So at the beginning, PRRT was a very limited experience. Geographically, it started in Europe, in Rotterdam, Basel, Switzerland, Milan, then Vienna, London, and nowadays we can see that PRRT expanded like daylight, and we have PRRT experiences in the United States, in South America, we have PRRT experiences in India, we have PRRT here, we have PRRT in Australia, so it is really expanded. The main radiopeptides that are used for PRRT are two somatostatin analogs, two modified octreotides. The first one is called yttrium-DOTA-TOC or yttrium-DOTA-octreotide, where the modified octreotide is related to a special compound which is named DOTA, which holds tightly the radioactivity. In this case, it's yttrium-90, which is a powerful, high energy and long penetration range beta emitter. The other compound is named lutetium-DOTA-TATE or lutetium-octreotate or thiophene-3-threonine-8 octreotide. And the difference, apart from the octreotide, is that we label this compound with lutetium-177, which is an isotope with a lower energy and penetration range, but with a longer half-life and a gamma emission, so an emission of photons which are used for imaging and dosimetry at the same time, as we will see. So we've been using these peptides for 18, 20 years, depending on which one we are considering. Despite the lack of homogeneity among the studies, what is it that we have learned from these trials? So we have learned that this is an efficient therapy. We observe tumor shrinkage, tumor responses after this therapy. There is a symptom relief and an improvement of quality of life. There is a biomarker reduction, and there is an impact on survival, which is the most important parameter that we want to address. And as to the safety point of view, the tolerability point of view, generally this therapy is well tolerated, and the side effects may be divided in acute and chronic. The acute side effects are generally mild, mainly nausea, sometimes related to the co-administration of amino acids which are used for renal protection, or fatigue, which is mainly related to the administration of the therapy itself. The chronic effects are also mild if the necessary precautions are taken, and mainly involve the kidney and the bone marrow, as we will see. As I was mentioning before, the registration phase 3 trial for lutetium-octreotate is now ongoing finally. So usually a PRRT is proposed inside a neuroendocrine tumor board. Each option is discussed for the patient, but usually it is proposed in unresectable or metastatic G1, G2, so well to moderately differentiated neuroendocrine tumors. It doesn't matter if they are functioning or non-functioning. They have to be somatostatin receptor positive, so they have to show up on the somatostatin receptor imaging with octreoscan or PET with the gallium peptides. Usually we treat patients at the early progression to somatostatin analogs or other molecular targeted agents. If possible, we like to treat the lowest amount of disease as possible. So if the patient is amenable of surgery or liver-directed therapy with, for example, with chemoembolization, radiofrequency or sample radioembolization, we prefer to have these treatments precede PRRT and then have PRRT in order to control the syndrome, the growth, or even to eradicate the disease. Usually PRRT is performed upfront in the setting that I described, so with the aim of controlling the syndrome, the growth, and possibly to induce a reduction in volume of disease, and then allowing us to send the patient for further treatment with surgery or liver-directed therapies. Let's see some examples. This is a patient affected by a pancreatic VIP secreting neuroendocrine tumor treated with yttrium-beta. You can see here the basal imaging, the big lesion at this axial slice at CT scan, and this is the octreoscan planar view, anterior view. You can see the very high uptake to this lesion, and you can see the response after the completion of treatment with yttrium-beta from a functional and morphological point of view. An example of patient treated with lutetium octreottate, a patient with a pancreatic G2 neuroendocrine tumor. You can see a very big lesion involved with the body and the tail of the pancreas. The biggest one of the liver lesions. This is the simultaneous imaging with octreoscan, and you can see the response both from a morphological and functional point of view after the completion of treatment. When we talk about response, we talk about tumor shrinkage, which is an occurrence which happens in 15 to 35% of patients. But what's most important in these patients is not only to have a volumetric response, is to have an impact on the quality of life, on their symptomatic management, and on the parameters of survival, as we say. So let's examine the symptom relief. With lutetium octreottate, for example, it's been demonstrated that there is an increase in the global health and quality of life of these patients. And of course, this is an occurrence which happens in patients who show regression of disease. But also, surprisingly, it happens also in patients with, who don't respond to PRRT. So they have, anyway, a symptomatic relief, a symptomatic amelioration. Let's have a look at the survival parameters after lutetium octreottate. It has been demonstrated in the big series of patients from the Rotterdam series that in patients who show at least a stabilization of disease after lutetium octreottate, there is an overall survival which is greater than 48 months. And the median progression-free survival, so that means the median time to have of the control of disease, so to have a progression of disease is 33 months. So it is these are data that compare very favorably with chemotherapy or other therapies, as we will see. Yttrium octreottate has been demonstrated. This is the big series of more than 1,000 patients in the Switzerland series, that patients who have disease control and who have a high tumor uptake at the basal scan, they have a longer survival from the time of the first PRRT. And when we compare the treatment with PRRT with other therapies, this is the result of an analysis, of a sub-analysis of the big group of 310 patients treated in Rotterdam. Dick Reckerbom separated his, divided his series in groups comparable to the various studies in literature where patients were treated with other treatments available, like chemotherapy or other therapies. And in every case, the comparison was in favor of PRRT. So lutetium octreottate, in this case, was able to obtain a survival benefit, which ranged from 40 to 72 months from diagnosis and 12 to 21 months from therapy start. So even if it's not the result of a proper study, statistically designed randomized studies, this is certainly a huge difference which is in favor of PRRT. Dosimetric studies. Dosimetric studies are not very common in PRRT. It's difficult to have a dosimetric evaluation in each patient at each cycle, but every nuclear medicine doctor would like to have a study at least in one of the cycles in each patient. That means that when we have a dosimetric study, we need to study the doses, the absorbed doses, the radiation doses to normal organs involved during the therapy and the tumor. We can do that before the therapy as an en blanc procedure, or during the therapy, possibly at the first or second, third cycle of therapy, in order to plan accurately the therapy itself. The issue of dosimetry is debated, but nevertheless, dosimetry allows an insight for optimization and helps maximizing the dose, the radiation dose to the tumor, while minimizing the dose to the normal organs. And as we wrote in the guidance documents that we published under the auspices of the International Agency for Atomic Energy, the European Association of Nuclear Medicine, the Society of Nuclear Medicine, we stated that if feasible, a patient-specific dosimetry is always helpful because it can provide valuable information for the organ absorbed doses and in that patient. So what does it mean? Dosimetry means simulating the treatment and calculating the absorbed doses, the radiation doses for each organ, and in particular I'm referring to the so-called organ at risk, and as we said, the bone marrow and the kidneys in particular. So if we are using yttrium-90, we know that yttrium-90 is not very well suited for imaging. There is not a photon emission that allows us to calculate the distribution, exact distribution of radioactivity in the organs. So we have to do some tricks. So we can have some quantitative analysis of the X-ray, a particular type of radiation which is emitted by yttrium-90, and if we have sophisticated machineries, we can quantify that. We can use a sort of cousin isotope, which is indium-111, which is similar, as a chemical behavior similar to yttrium-90, and so we can mix yttrium.atok with indium.atok and make our calculation, so we can make a pre-analysis before the therapy. Or we can use yttrium-86, which is a very sophisticated isotope, which is available only in few centers. The University of Leuven in Belgium made a lot of studies, but it's not available everywhere. Or, more easily, if we are treating the patient with the tissue, we can use the same compound during, in other words, during the therapy, during the first course or the second course or the third, I wouldn't go much further than that, we can calculate the distribution of radioactivity in the organs, and from that, with special modeling, mathematical modeling, we can calculate the dose of radiations which is delivered to the various organs in the body, and in particular the organs that we are considering the most, the kidneys, the bone marrows, and the tumors. So what we calculated as I already mentioned, these are the doses in the organ at risk, the red marrow and the kidneys, as expressed in the literature. As you can see, these are the organs that we are more concerned about. Let's talk about the clinical significance of dosimetry. We know that adverse events of PRRT are rare, because PRRT is well tolerated in the large majority of patients. When we talk about long-term events, these include loss of renal function, which is more marked after yttrium peptides, as we can see here from the dates, from the data of the literature. Less marked after lutetium peptides. More rarely, as a rare occurrence, we can have the occurrence of myelodysplastic syndrome, or in very, very rare cases, leukemia. So these are very rare events, but nonetheless, they have been reported in the literature. So is dosimetry able to predict this event, or to help the physician to predict or control these events? Individualized dosimetry. As I said before, it is a very debated subject. There are pros and cons. Those who are in favor of dosimetry claim that the calculation of absorbed doses or biological effective doses delivered to normal organs and tumors allow us to better categorize the patient and to plan the treatment. So we can optimize the treatment, we can estimate the cost-benefit ratio in the single patient, and by calculating which dose we are going to administer to the patient, we can see if the treatment is feasible, if we are likely to exceed the thresholds of toxicity or not. According to the dose of radiations that we are delivering to this to the organs at risk, we can calculate if the treatment that we are planning is likely to deliver the sufficient amount of radiations to the tumor, so if we can eradicate the tumor, or if the treatment won't be able to eradicate the tumor, so we have to palliate in that case. We can adapt the treatment to the clinical condition, so it makes the treatment more flexible. What do the detractors of these techniques say? They say that it's time-consuming, that it's resource-consuming because we occupy the machineries for several days. In some cases, may not be exact, as we will see, and may shed a certain light of danger on PRRT, which is not what we want. And this is a fact, severe toxicity is rare, especially with lutetium peptides. However, it has been demonstrated that if we do peptide receptor radionuclide therapy with a fixed amount of cycles, let's say the classic Rotterdam protocol of 4 cycles of lutetium maltretate, and if we take into account the thresholds of tolerance of the bone marrow and the kidneys, we can see that patients behave differently. So there are the majority of patients who can tolerate the 4 cycles of 200 millicuries each. There are a consistent number of patients who can tolerate less than 4 cycles, but there are many patients who can tolerate more than 4 cycles. And another interesting issue was that kidney wasn't always the dose-limiting organ. It is in the majority of cases, but in sometimes patients should stop because of risk of myelotoxicity. So is dosimetry always a niche issue? Is always something that physicists like, but doctors find completely useless? Let's see. These are some calculations, but I'll try to guide you through. So if we hypothesize to give a patient a treatment with lutetium peptides, and we divide the treatment in several cycles, or we divide the treatment in few cycles, you can see that the resulting dose to the kidney is different. But it's much more different if we do this thing with yttrium peptides. So if we hyperfractionate, as we say in a medical term, so if we divide the treatment in multiple cycles, or if we divide the treatment in in less cycles, we can see that the resulting dose to the kidney may be very different and may be high for the so-called hypofractionated treatment, so the treatment where a big amount of radioactivity is given in a single cycle, few cycles of very high activity. So PRRT doesn't always have the same impact, and dosimetry allows us to calculate that. So different schedules, different doses to the kidneys. And I'll try to guide you these very complicated graphs. If we use the same schemes as before, so if we use different schemes of fractionation of PRRT, we can see that we can exceed the threshold of tolerance. We can have different losses of function in the various schemes, especially if we're using yttrium. So some schemes may leave the patient in a very vulnerable situation. Some non-standard patients may be left with toxicity even at standard dosages. So dosimetry allows us to calculate which patients are more vulnerable, in which patients we are likely to exceed the thresholds of tolerance to PRRT, of the kidneys, for example. And moreover, we demonstrated with dosimetry that patients with clinical factors like long-standing and poorly controlled diabetes or hypertension have a lower threshold of tolerance to PRRT. So in these patients, we should try to be more conservative and possibly to switch to lutetium therapy. The bone marrow. The bone marrow has two types of toxicity. There is a subacute toxicity, like hematological toxicity, which is very mild or moderate in the majority of patients, can be severe, transient in not more than 10, 12%, 13% of patients. And as we said, the long-term events are rare. However, with dosimetry, we can see that there is, if we correlate the cumulative dose to the bone marrow to the toxicity shown by the patients, we can see that with the increase of the radiation dose to the bone marrow, there is a certain impoverishment of bone marrow reserves. And this is something that we have to know and we have to take into account. And again, dosimetry allows us to optimize and calculate these events in each patient. When we perform dosimetry for the bone marrow, our results are less exact as opposed to the dosimetry for the kidney, because actually there is not a strict correlation between the doses to the bone marrow derived from our methods of calculation and toxicity. The dosimetry is less stringent for the bone marrow because of the methods that we are using to calculate the dose. So someone hypothesized that possibly there is not just the irradiation to the bone marrow because of the blood that circulates in the bone marrow, and that is the cause of the irradiation. There must be something else causing the irradiation to the bone marrow, and someone hypothesized a binding of yttrium or lutetium to a protein called transferrin that may relocate in the bone marrow, and this could account for the toxicity. So the models must be refined. So towards individualization of PRRT, we need to perform dosimetry, possibly in each patient, at least in one of the cycles of therapy, including radiobiology parameters, so that we can define the categories at low risk or high risk for toxicity, or the categories that may respond to therapy or may not respond to therapy according to the dose to the tumors that we are delivering. But we need also to integrate the dosimetry data that we are calculating with the biology of tumor and normal organs, so that we can better select the patients. And we need also to integrate the dosimetric data with the genetics of tumors and normal organs, so that we can better understand the functioning of the therapy. We can better understand how the patient responds to the therapy. Because possibly in a very near future, we can measure the radiosensitivity of the normal tissue, so how the tissue is going to respond to the absorbed dose, to the radiation dose that we are delivering. And possibly, we can measure the radiosensitivity of the tumor, so how the tumor is going to respond to the dose that we are delivering. Because as we can see here, the probability of controlling the tumor for the same dose that we are delivering is different according to the radiosensitivities. And if we know this parameter, hopefully in the near future, if we can know in advance the radiosensitivity of the tumor, we can predict if the tumor is likely to respond to the therapy or not. So if the treatment is likely to function or not, if the treatment is likely to be effective or not. And we can predict that with a very high degree of accuracy. So with dosimetry, we can say that really one size does not fit all. So I would like to conclude by saying that dosimetry allows the individualization of treatments, and the individualization of treatment in the future will be based not only on dosimetry, but also on the biological information and the genetic characteristics of both the tumor and the normal organs. And with that, I would like to thank you for your attention, and thank you for the attention for a very complicated subject. I'm very glad to reply to answer any question or any issues that may have come out. And I would like to acknowledge our group, Nuclear Medicine Department and IO in Milan, our immunocoming tumor. Thank you very much.
Thank you, Dr. Bodei, for your insightful presentation. I think now I would like to invite questions from our audience, if there's any.
Any question? If not, let me start off by asking Dr. Bodei. Most of the cases that ended up with me, what I witnessed is some of the jaw-dropping response. But from your database, about 1,000 patients, how many in actual fact can be reduced to such an extent that cytoreductive surgery becomes possible?
Well, this is a subject that hasn't been addressed per se. It's in discussion at the European Neuroendocrine Tumor Society, the Nuclear Medicine Society, where there are two proposed dedicated studies, prospective studies, not just reports or retrospective data on a few patients, so that we can have a serious analysis on this subject. For the moment, there is no definitive data.
Do you have any retrospective data based on the 1,000's database? What is the proportion in the ballpark figures?
The 1,000 database was the experience of the Basel group. There is no mention.
The data,
there's no extrapolation of this kind of data. Okay. But there are reports in the literature, so there are signals in reviews and signals in limited series and signals in abstracts of this kind of experience.
The second question is, I noticed that in your protocol, patients on PRT are also put on plus or minus interferon or targeted therapies. How do you select your patient for this too, rather than the sensitizer like Peptide?
Well, it's a very interesting question, because for the moment, in the absence of a registration and of randomized studies, for the moment, we don't know the exact position of PRT in the therapeutic algorithm of neuroendocrine tumors. what we know is that as opposed to 10 20 years ago when PRRT, or 15 years ago when PRRT was proposed at the very end stages of disease, we know that it is more effective when it is proposed earlier in the story of the patient. So for the moment we try to propose it, so it is a tentative positioning of our therapy. So as a tendency, it is proposed at the early progression to the standard of care, which is somatostatin analogs. I put also interferon because there are other groups who are Scandinavian who use interferon as a standard of care. I put also other biological therapies because if we are talking about pancreatic neuroendocrine tumors, drugs such as everolimus or sunitinib are approved and may come before PRRT.
How about our audience? Question?
Hi, Dr. Bodei. I had my PRRT treatment 7 years ago in Rotterdam. I had three rounds of treatment. I can't go for the 4th round because I only have 1 kidney. And the doctor who attended to me told me that if there is a recurrent, I can only go for PRRT for 2 courses because of my kidney. So what is your suggestion? Should I go for the dosimetry to see whether I'm eligible for the PRRT treatment, or wait for the 5 tumor in my stomach to grow to sizable size so that I can go for surgery?
First of all, I cannot opine on the details of your case because I don't know the details of your case, but in general, if possible, it's not an obligatory procedure, but if possible, dosimetry allows for a more accurate calculation of the allowance, let's say, that the patient has in terms of the ratio between costs or risks and benefits. And sometimes we can decide together with the patient that the benefit of the therapy exceeds the possible risks of renal of loss of renal function, also because the end stage, let's say, losses of renal function, so the need for dialysis is something that occurred very, very rarely in the literature. If there is a good renal protection with the amino acids, which I'm sure that you did when you went to Rotterdam, a good fractionation, usually renal toxicity is a rare event. In your case, I would need to check your lab values to see, you know, the risk-benefit ratio. But I'm sure if it's been proposed to you, there is allowance to do that based on your, at least on your all your examinations and your lab tests.
Okay. I have a question.
I just want to ask, with regards to PRRT side effects, we know that the radionuclide actually is taken up pituitary gland. Do you have any comments with regards to any side effects seen can have a bit or whatsoever?
Well, actually, it is something that we all asked ourselves at the beginning of this experience, whether we were damaging the pituitary. So the pituitary axis have been checked and rechecked by, I think, every group that had this PRRT or initiated this PRRT experience, but no toxicity was observed.
Any other question or questions on the conference?
Arthur Ray asked a question. Arthur Ray asked a question. He was asking, are there any specific tools or tests that are carried out to determine the dosimetry for individual patients?
in order to do the dosimetry, for the moment, what we do is a scintigraphic study before or during the therapy, consisting in at least 4 or 5 scintigraphies, 30 minutes each, let's say, not more than that. It's a normal total body scintigraphy, anterior and posterior views, and then all the images are passed to the physicist who calculates through complex algorithms and mathematical modeling from the activity distribution. So the distribution of radioactivity in the image can calculate the absorbed dose to the lesions. So it's a matter of doing a scintigraphy. And collection of few samples of blood, very small amount, and collection of the urines during the period of the scintigraphy.
And there's another question from the conference. Humphrey Wheel in South Africa wants to know, is there a move to standardization everywhere in the future forming part of all PRT treatments?
Well, that's a very, very interesting question because PRT started off as an experience which was related to the center. It was different in each center it was proposed. Nowadays, there is the guidance document that we agreed upon. All the major actors in PRT agreed upon the procedure, how to perform safely and efficiently PRT. So that was the first step. There is a registration trial, as I mentioned before, ongoing, which is aimed to register PRT with lutetium at a certain standard dosage, 200 millicuries times 4 in small intestine neuroendocrine tumors. These are all steps towards standardization.
That's it.
Any more question? How about the front? David, do you have any question?
Yeah. Dr. Bodei, thank you for your very, very interesting and very enlightening talk. I just have a question for you. How do you actually do your dosimetry? You do a pre-treatment dosimetry study, is that correct?
We can, if you are treating patients with yttrium, we can do a pre-treatment dosimetry with indium,
right.
The indium compound. We can do that before the therapy, or more easily, for logistical reasons and practicality, we can mix indium and yttrium to in the same vial and administer the mixture to the patient and start with dosimetry immediately after therapy.
Or the first cycle of the therapy?
I would prefer to do that at the first cycle because then
right.
we can plan more exactly and more safely and more efficiently what we are doing.
And after you have done the dosimetry study after the first cycle, how does that result of the dosimetry study affect the choice of your activity to be administered on the second? How does that affect?
Well, a very interesting point. We had patients also in the lutetium trial who showed to have a very high dose to the kidneys despite the kidney protection with amino acids. So what we did was to limit the amount of cumulative activity to the minimum known to be efficient, and we didn't escalate up to the maximum tolerated cumulative activity. So that is a first example.
Right.
Any other question? Can I ask, what is the average cost for doing the dosimetry? And in the pre-dosimetry era compared to the current era, what is the absolute reduction in the morbidity and mortality? Can we justify the cost effectiveness in doing dosimetry for every patient or on a selected basis?
For the moment, it has not been calculated as such. I'll give you an example. There is a rate for the moment of dosimetry exams. It's like 5 to 10% in the most active centers, 15% of patients who get dosimetric studies. But the cost-benefit ratio is, of course, in favor of an individual calculation. I showed you the data by Sandstrom and co-workers, who showed that patients treated with a fixed dosage and a fixed schedule of PRRT may result in different outcomes. There are patients who can tolerate much less than what is normally administered, and there are patients who are undertreated. So you could have done more. You could have probably given an eradicating dose to the tumor.
Can I ask a question from behind you? Sure. Sorry to interrupt, and I'm asking a question about a subject I know nothing, but that's never stopped me. What's the cost of not doing it? That would be more important to me. I mean, what do you lose by not having dosimetry in a patient?
Of course, it's the risk of toxicity. The risk of toxicity, which would be unpredicted in that kind. In that situation. So even if toxicity is not the major outcome of, so it's not that common, when we do dosimetry, we can target the schedule of treatment to an efficient treatment and a safe treatment. So we can maximize the efficiency while minimizing the toxicity. The cost, of course, is going blind. And going blind has never done any good.
You wouldn't want to go blind, would you?
I think with unlimited resources, all the patient would like to have the dosimetry. And I saw your pros and cons table. I'm not quite sure whether I appreciate the cons. Maybe you want to explain a bit more on the cons.
The cons, well, the major one by the detractors is that it's time consuming because you have to repeat 4 or 5 scintigraphies. So you occupy the gamma cameras. You're not producing, let's talk politics, you're not producing exams which are reimbursed or paid by someone.
And more importantly, are you depriving the second patient from the PRT treatment? You're taking lots of time for one patient.
No, that's not the case.
So the patient there's a long queue to come in.
That's not the case. You're occupying the nuclear medicine department with exams which are not paid or reimbursed for. And you occupy quite a great amount of time of a physicist who has to do the calculation. Talking politics, one possible solution which we are trying to push in Europe is to try to get to make a lobbying activity to get a reimbursement for dosimetry, so to make dosimetry as a standard procedure. That is the first step. The other cons, the major one, is that dosimetry is not always predictive. That is the case sometimes for the bone marrow, not for the kidney. More refined methods of calculating the dose to the bone marrow are presently being developed, as I mentioned, and these will hopefully lead to a better prediction of what's happening in the bone marrow. And possibly, as I mentioned in the final part and in the conclusion, integrating radiobiological, biological, and genomic data to what we're doing will help increasing the accuracy of the dosimetric analysis and to make an exact prediction individualized to the single patient.
Is there any concern about its interference in the PRRT treatment per se?
No.
Does the dosimetry has any interference in the subsequent treatment?
If you mean that the subsequent treatments could be modified,
Yes.
that's a welcome event, because if you are modifying the treatment, you're modifying the treatment according to the patient's needs.
No, what I mean is the compound that you use to do the dosimetry, does the compound tracer, is there any interference with the subsequent tracer that you use, or you can use any tracer because limit the...
If you're using indium mixed with yttrium, it's a diagnostic amount, so it's not influencing anything else than imaging and our dosimetric data, so it's only used for production of data. And if you're doing dosimetry with lutetium, it's you don't need to inject anything else. You just use and make calculations with the activity that you give for therapy.
Okay.
May I ask a question? So we understand that actually they have dose limit for different organs, like for the kidney is about 27 gray, for the bone marrow is about 2 gray.
Yeah.
So let's say this patient go for the first cycle treatment and he hit the limit already. But after a few years, the organs will heal itself, recover from the damage of the first cycle. So will it be suitable to go for the second cycle? What is the time interval in between these two treatments?
Well, first of all, it's highly unlikely, I would say, or virtually impossible that you hit the limit with one cycle, unless you are giving a very high amount of radioactivity, which is outside the standards.
When I mean one cycle, I mean actually the full therapy. So,
okay,
yeah,
so one treatment.
Yes, one treatment.
And so your question is that if you give a whole course of treatments and you hit limits, then well, if we talk in radiobiological terms, the tissues in the kidneys are a slow turnover tissue, so the possibility of recovery, at least in the immediate period, is low. So I would wait at least 5 or 6 years. But it's debatable whether you should retreat the patient once you've hit the limit. And in this case, I would use the bioeffective dose rather than the absorbed dose for the kidneys. But
thank you.
Any other question? Just to, oh yes, please.
Some people have been using 68 DOTA peptide PET scan to try to estimate or help in the estimation of the activity to be given. Do you think that it's possible, or what's your comment?
well, if we are considering gallium peptide PET as an estimation of the distribution of the density of somatostatin receptors, so the uptake. So if we want to make a rough estimate on the uptake that will result after the administration of lutetium or yttrium peptides, that's something that of course is done and everybody does. If you want to make dosimetry with gallium peptides, this is not advised because the chemistry and the affinity and the biodistribution is slightly different, and it could alter the results and give rise to error and imprecision in the calculation. So it's not advisable to use gallium for dosimetry. Plus the half-life is so short that you would have to leave all the final parts of the curve to extrapolate, mathematical extrapolation, so you would most likely introduce errors.
Any other question from patient support group or from caregiver, the resident, the fellow? If not, let me sum up the message to us is, even in the face of the imperfection of dosimetry, it still appears to us that there is a utility for using dosimetry for the objective of minimizing and reducing the morbidity and mortality of PRT treatment. Is this message correct?
I would say yes. There is a strong evidence supporting that dosimetry minimize morbidity, at least mortality. I wouldn't go that far, but for certain morbidity, yes.
Thank you. Should we have a break or should we continue?
We should continue. Yes.
We should continue on.
Thank you, Dr. Bodei, for your presentation. Now we